so now we're going to go ahead and start with a review of lumbosacral assessment in your patient. And this is a generic exam. It's not a detailed exam by any means, but it gives you a framework that you can work around. So we're assuming that your history has been completed, so you have a pretty good idea of the conditions you want to rule in or rule out with your differential diagnosis list and key tissues that you want to assess within this patient. So we're going to go through from that point, and you're going to give your introductory statement. I'm going to perform a physical exam. It's going to involve a hands-on assessment, and if anything is painful or uncomfortable, please let me know right away. And don't let me do anything that you think is going to cause you further injury.
Okay.
Okay. All right, so that develops rapport with your patient right to start with. You've given clear instructions. They know what's to be expected for the rest of the exam. To start with, you're going to go through inspection. And inspection usually starts with a postural evaluation, so just simply we'll have the patient stand up right here. And you want to stand a little bit away from the patient. She's going to be facing forward and just arms at your side, and maybe even take a few steps. Do absolutely not use the word posture when you're checking somebody's posture. Just say, I want to see how you normally stand. What happens when I say posture? Okay, everybody's all up like this. Oh, this is how I normally stand. Yeah, right. Okay, all right. Other key thing that I'll do, especially if you're a taller practitioner, is I'll get down low so you're at the level of the patient. Key things you want to look at is you might look at arms different from side to side. You might go ahead and also look at iliac crest heights, ASISs, things like this to see if they're the same or different. And the only way that you really can see this is when you're down low for your inspection. Okay? Don't be tricked by the clothes. If somebody's wearing clothes that are tilted off to the side like this will make you think, well, they got a pelvis that's shifted off to the side like that. No way. You've got to get in there and palpate that structure. Okay? What else would I suggest? I would suggest you use a posture chart to get a real assessment, and we'll go ahead and stand there for just 1 second right now, to get a real accurate assessment of what's going on with the overall shape of the patient's body and the inspection parameters you're looking at. Let's go ahead and turn to one side. And if she turns, key thing to look at here is you're going to potentially look at the angle of the pelvis itself, so you can check ASIS and PSIS and kind of get a rough gauge for the angle of her pelvis. You want to see the curvature. She might be hyperlordotic, where she's way back like this. She might be hypolordotic, where she's really has that flatter spine and brings them around like that. Key thing here too is you have to have clothes, or at least your hands, be able to roll over top of the area. If this was a really baggy shirt, what would happen is I wouldn't be able to see the shape of that spine, and I have to be able to see the shape of that spine. Physical observation is also of benefit as well. You may want to have the patient in a gown or a sports bra or something like that where you can really see the tissue, just to make sure there's no abrasions, bumps, swelling in the area. All right, that would be a key thing. And we'll have you turn around just one more time for us, and she's facing that way, same thing. Now I'm going to block the cameras a little bit when I do this, but realistically, what are you doing? You're finding iliac crest height, PSISs, and just comparing bilaterally. You can do the same thing, find the the greater trochanters, and find the top of the greater trochanters. You can even look at the shape of gluteal folds. What can happen is one gluteal fold will be different than the opposite side. And of course, your postural assessment would always start at the feet. You'd work your way up from the bottom up to the top. So, okay, Carly, we'll go ahead and have you sit right here. Anything else you want to add to the postural assessment?
No.
No, okay. Okay, so you've gone through your initial inspection. The next thing is going to be palpation. Excuse me. Next thing is going to be palpation. Now, I realize that for palpation, it's better done if the patient is prone, but for the simplicity of your exam, you might just want to start within a seated position before you have them lay down. One of the worst things that happens in an exam is you have the person lay down, then you have them flip over this way, then you have them sit up, and you have them jumping in position. If you have an acutely injured patient in front of you, you don't want them moving around a lot, so you have to be able to perform most of your tasks in multiple positions. So, for basic palpation, Carly, we'll have you turn around and face the opposite direction. In a seated position, what would I do? I would start, well, a couple of different ways you can do it. You can start down nice and low like this, and you just see what's going on. Palpate the bony architecture. You kind of already started your palpation with the postural assessment, but PSISs, roll into the multifidi, erector spinae. Remember the purpose of this? You are giving an anatomy lesson of the structures below your hand, okay? Up here into the abdominals, the external obliques, internal obliques, transverse abdominis are all starting into this area. Maybe get into the midline, feel the tension in the erector spinae, and these are pretty tight erector spinae, but she's sitting pretty straight right now. Okay, maybe you want to work your way up into the erector spinae as they get into the lower thoracic region as well. You can go ahead and push down a little bit further, outline the sacrum a little bit there if you'd like, and over top here, TFL, glute max, glute med, all of that stuff all the way through there. Again, really that assessment is performed better with the patient laying prone, and you get a more detailed examination of that area. The other thing you want to look at is even the shape of the abdomen too. So if she turns around and spins this way, again, you really wouldn't have the patient spin around like this, but just for the ease of the camera, we're doing that. This is important. If she's got a belly, okay, maybe what's happened and she's not pregnant, she's got a belly out like this, it's going to tell me that she's predisposed to maybe some abdominal weakness that will give a counterbalance issue for low back pain and issues on the other side. Core strength and the observation of it is a key thing for you to look at for our low back pain cases that we see, so please pay attention to that one. All right. And palpation, of course, you can go into abdominal exam and all that stuff if it's part of your DDX and you're trying to rule out those pathologies. Next thing is going to be range of motion. So for range of motion, simple instructions. We have the patient stand up. I'm going to take you through a range of motion assessment. If anything is painful or uncomfortable, please let me know right away, and don't do anything you feel will cause you further injury. Okay? So you're going to bend forward, and as far as you can go, good. Little cracking there, good to hear, and then all the way back up. Okay? And we'll have you lean back. Okay, all right, you're moving around, that's good. We're loosening up finally. Okay, over to the side like this, and over to the side like that. Key outcome markers you can use, again, postural assessment chart can give you that where you can measure them, but one of the ones I like to use for lateral flexion, when she leans down, I usually like to just measure on the side of the leg, how far could she move? When she leans the other way, on the side of the leg, how far could she move? Look for that bilateral symmetry, and physically how far the range of motion is. Rotation, we'll have you spin to one side, and we'll have you spin to the opposite side. Now a tricky thing happens here, the hips automatically rotate and spin you around, so you want to try and eliminate that. Easiest way to do it is have the patient sit down. She sits down and then she's just going to spin to one side. You've eliminated the lower body motion, and now she's going to spin to the other side. Okay? Resisted range of motion, fairly simple to perform in this area as well. So she's going to, passive range of motion I should do first. Let's just do it this way for a variation, okay? So go ahead and give yourself a hug. Okay, the purpose of this hug is to give the practitioner better leverage, and it's also to protect the patient for any incidental contact where your hand might be brushing over top of their chest or anything like that. So to start with, 3 points of contact, hand over hand, elbow over elbow, shoulder into shoulder. It's a nice balanced position, okay? The next issue is most people are going to sit fairly straight. Give that little wobble at the start and get them to relax just a little bit. Perfect, there you go. And then she spins to the side, and when she gets to the side, I give over pressure, okay? And I'm just using my thenar eminence, pushing into the spinal laminar groove, and just a little bit of overpressure. This is where your assessment becomes therapeutic potentially. We're going to do lateral flexion, lean her to the side, body weight comes in, and then overpressure, overpressure. Okay? All right. Go ahead and switch sides to compare both of those right away. So for rotation, spinning around. Oh, there was a cavitation right there as we moved, and that's pretty common. Okay? And then we're going to go ahead and have you lean to the side like this. Little popping of the joint. And I would suggest that that's probably a good thing. Okay? Flexion extension. For flexion, usually this is not the best way to check it. You've already done it with active range of motion, really. But for flexion, she leans back, and then I lean her forward like this. The problem that I have with flexion like this is it winds up jamming the elbows into the abs, so it's usually pretty limited. Realistically, it's not an action that's limited that much for patients. If you actually look at the shape of the lumbar vertebrae, anatomically they're designed for flexion extension type motions, okay? The real limiter that I've found for most patients has been just tightness in the erector spinae and the tightness especially of the lower multifidi in that area as well. For extension, hook underneath the elbows. I'm going to lift you back and up and give a little bit of overpressure just to lift back and up, all right? For resisted range of motion, usually you don't have to do this, but if you did, she would still be in the same position. I'm going to try and turn you this way, turn you that way. It is warranted for, again, that core body weakness, okay? If they have weakness in the abdomen or maybe they have diastasis recti or something like that, you want to get a base function for how they can actually move. Core stability is fundamental for the prevention of low back pain. All right. Anything else you want to add?
Nope.
No. Okay, so history, inspection, palpation, motion. Now, neurovascular screen for the lower extremity is a pretty important exam, and it does start off fairly high up. So the lumbar plexus, you're looking at lower lumbar and into the sacral spine. The neuro screen can include motor function, sensory, deep tendon reflexes. To start with, we'll just do the DTRs super fast. So what are your deep tendon reflexes? Again, comparing bilaterally, deep tendon reflexes are L4, patella, L5, medial hamstring, and then S1 is going to be Achilles. Now, a couple of key things, if you're really going to check these, we'll have you slide forward just a little bit. Yeah, perfect. Is that if she's too far back on the table, you won't be able to grab that medial hamstring. If her legs are too far back on the table, you might not actually see this extend out. So when you're really checking reflexes, I would suggest you actually palpate the muscle and then tap it at the same time, okay? Okay. If you're fast, you can do it with your hand, or if you have good reflexes like she does, you can do it with your hand, okay? You know, you don't just have to have a reflex hammer. Yes, it makes it easier, but you can be quick with your hands and actually make these things happen. Okay, if I lift up, yeah, I can just feel the medial hamstring, and even right here, if I tap fast and hard, you can actually feel the foot drop down just a little bit. Okay, so it's going to be L4, L5, S1. All right, so that checks those spinal levels, probably the most commonly injured in radiculopathies like disc herniations or IVF encroachment secondary to an osteophyte. What else do we want to check? We can check sensation. So sensation for the lower extremity, we'll just have you back up just a little bit. What are our dermatomes? Our dermatomes basically roll down the front of the leg like this, and the instructions you're going to give to the patient are, I'm going to perform a neurologic exam. I'm going to lightly brush my fingers over different areas of your legs, and I want to know if it feels the same or different from one side to the other. Okay? And you're going to close your eyes while we do this so you can't cheat. Okay? All right. Okay, so I'm going to go right here. This is going to be roughly L1. Same. Okay? L2.
Same.
L3.
Same.
L4.
Same.
L5.
Same.
S1, different. Okay, you got to check them. Always make sure you do same, and then go different. Compare them again, and then just for full completion, check the bottom of the foot really quick as well. That takes you through all of your dermatomes. Realistically, if you had an index of suspicion of a lack of sensation in one area or another, you would go into a more detailed exam that would include things like sharp, dull, maybe even hot, cold if you're being very specific, or a referral to a neurologist who would perform those exams as well. Anything else for the neuro you think of?
An important thing for neuro in this area is going to go back to a patient's history where they explain any symptoms of numbness, weakness, and tingling.
Yeah.
It's relevant in this area.
Yeah.
And even comments like, my pain is worse when I sneeze or cough.
Excellent. That's a really good point. I mean, that's part of the history as well, that coughing, sneezing, straining, that's your pathognomonic findings for disc bulge on the nerve roots. Yeah, really good point. Okay. Anything else for the neuro? Yeah, you could actually do motor assessment for the neuro lower extremity as well. So you can actually have the patient lift her leg up. She's going to hold it up right there, and I'm going to try and push it down. Don't let me do it. Hold, and relax. You're checking hip flexors right there. I'm going to try and lift this leg up this time. Don't let me do it. Hold, and relax. A couple of things you noticed about that when I did it. I'm using my body weight to stand over top, so it's easier for me to perform that, okay? Next thing is going to be flexion extension of the knee. So I'm going to try and pull your leg forward like this. Don't let me do it. Hold, and relax. I'm going to try and push your leg forward this way. Don't let me do it. Hold, and relax. You could check if you wanted plantar flexion and dorsiflexion, but you will never be as strong as the patient is themselves unless they have extreme weakness with it. This part of the motor assessment right here, you want to do bilaterally as well. The easiest way I've found to do this is have the person stand on their toes. Okay, she can lift her body weight up and watch how they do that for both sides. So she lifts up like that. That's going to be more L5, S1 area. Okay. All right, so this is going to be S1 when she pushes up like this. Excellent. And you switch from side to side to do it on one foot or another. And then if she goes onto her heels, this is going to be more L5. Okay, so it's L5 heel walk, S1 toe walk. When you see these neurologic lesions in practice, what do you see? The person goes to lift up and they can't lift with one side, or they have a foot drop gait or something like that. That shows you the muscle weakness, and you're just verifying it with your physical exam findings. Referred pain to the lower extremity is kind of tricky. There's a lot of things that can refer down here. Usually they're referring more up into the hips. A lot of the viscera can refer down. So if you have a kidney stone or pyelonephritis or something like that, you can have pain in the lumbar spine and the low back that can also refer down into the legs and potentially even into the groin itself. Disc herniations and other radiculopathies refer shooting pain down the back of the leg. SI joint can refer pain specifically down the back of the leg as well, okay, or not fully down the back of the leg, but usually up into this region. If you have numbness and tingling that goes past the knee, it is almost always pathognomonic for some kind of nerve compression somewhere in the lumbar spine, okay, or proximally along the sciatic nerve, okay? Special tests, you're going to pick which special tests you're going to perform later on. For my real examination of the lumbar spine, I would also have the patient lay prone. So if she can lay prone for us here really quick. Okay, patient lays down. Now all these muscles that were contracting before are all now nice and relaxed. So you can go ahead and push into the erector spinae. You can move from side to side and see even how the SI joint moves. This is that simple SI joint challenge where you're just pushing from side to side and just seeing how that SI joint springs back and forth. Outline the sacrum, see that it's midline, looking for any signs of tenderness or discomfort all the way through. And if you notice, I'm comparing bilaterally the entire time. Definitely finding that piriformis as it runs across right into this area, pushing in, all those short lateral rotators, okay? And of course, this would lead you to where you're going to eventually get to with your basic treatments as well. You can assess to treat right here. What's the beautiful thing about this exam? Everything was done seated, and this is the first time we've had the person lay down, and it's going to segue nicely into any treatments that we're going to give for them.